discussion, a special event for World Immunization Week on the Immunization Agenda 2030. Very briefly about us at IVAC and this seminar series. So we're based at the Johns Hopkins Bloomberg School of Public Health in the Department of International Health. And the International Vaccine Access Center aims to apply rigorous science to build knowledge and support and an understanding of the value of vaccines and encourage vaccine introduction around the world. We work with about 40 countries around the world and many vaccine experts. We ourselves are a diverse team of physicians, economists, epidemiologists, and vaccine advocates. This seminar series we hold monthly, and within the context of these events, we have had a very wide and diverse audience. I'm told that for this event, we've had registrants from over 45 countries, so that's fantastic, and we welcome each of you. We've long been connected with vaccine activities around the world for close on 20 years now, with many of you as well involved with us, so we're happy to have you. Currently, we're facing some difficult times, obviously, and our thoughts are particularly focused, I think, this week on the challenges being faced in the subcontinent, in India. But really, the global challenges of the pandemic have been enormous. The costs have been enormous on health, on well-being, on life, and on quality of life. And the world is looking really to vaccines as the opportunity to allow us to emerge from this pandemic. And it's in light of this backdrop, really, that the WHO, that UNICEF, that Gavi, and other partners are launching the Immunization Agenda 2030, which is an ambitious goal, ambitious strategy, really, to maximize the life-saving impact of vaccines through improved immunization systems. And not only focusing, as we traditionally have, on protecting children, but really strengthening vaccines, integrating them with health systems throughout the life course. We have pivotal actors and advocates that support this plan with us today, an expert panel, and we're very happy to have them, and also an expert moderator to help guide us through the discussion. Our moderator today will be Cynthia Gorney, and I'd like to just briefly introduce Cynthia and thank her for joining us. So Cynthia is a National Geographic writer who has served for over 15 years as a professor at UC Berkeley, at the Graduate School of Journalism. Formerly, she was a Washington Post national and foreign correspondent and has written for many magazines and publications, including the New Yorker, New York Times, and is the author of Articles of Faith, a frontline history of the abortion wars. For National Geographic, she's written about the crucial role of delivery and access and the challenges for pneumococcal conjugate vaccines for child health. She spent time in Bangladesh learning about the power of vaccines and has recently reported for the magazine on the pandemic's effect on science, nature, and culture. So I welcome Cynthia. We really appreciate having you. I'll let you present our panelists also. But I think, if I'm not mistaken, first we're going to be watching a brief video and then over to you. So thanks everybody for joining, and I hope we have a productive discussion. Thank you.
Today, I fight to give all the world's people access to vaccines because I have seen firsthand the importance and health impact of medical outreaches. It is no doubt today that the COVID-19 pandemic has truly highlighted the importance of giving every individual, regardless of where they live, access to life-saving vaccines, which are an integral and proven tool in preventing the spread of communicable diseases like COVID-19 in our ever more global and connected world.
I believe the vaccines save lives and save money. Do you know that over 7 million children in Nigeria that are born every year need vaccines to stay alive, especially for preventable diseases? Imagine these children not vaccinated. It will be terrible. Children are our foundation. Vaccinate them and do not allow them to be cut off.
वैक्सीन ज़िंदगी बचाती है और हम सब मिलकर ज़्यादा से ज़्यादा ज़िंदगियों को महफूज बना सकते हैं। आइए इस मिशन में मेरा साथ दें, ग्लोबल इम्यूनाइजेशन एडवोकेट बने, ताकि सेहतमंद माशरे की तश्कील में कोई भी फ़र्द अपनी एज, जेंडर और सोशल स्टेटस की बुनियाद पर गैर महफूज ना रहे।
Powerful. Good morning or good evening, wherever you may be. Welcome to all of you from all over the globe to this discussion of the Immunization Agenda 2030. As you know, the theme of this morning's panel is equitable access for all, a challenge that, of course, has been made much more complicated by the pandemic. We're grateful to be joined today by 4 leaders in the international campaigns for vaccine access and equity. I'm going to introduce them briefly here. And then after you hear from each in about an hour, as Andrew said, we'll bring in your questions, which you can write into the boxes below. And I'll try to pass on as many of those as I can in our 90 minutes together. So first, from Islamabad, Pakistan, Lubna Hashmat, a social scientist who heads the Civil Society Human and Institutional Development Program there. Lubna Hashmat, thank you for being with us during Ramadan. We know you will take a little time away from us shortly to pray and break the fast, and we will see you afterward. From Baltimore, we have IVAC's Dr. Chisoba Wolodi, who's on the Johns Hopkins faculty and works with a Nigeria-based group also called Women Advocates for Vaccine Access. From Washington, D.C., Martha Rabur, Executive Director of the UN's Foundation's Shot at Life campaign, which we just saw mentioned in the video. And from Geneva, the World Health Organization's Dr. Anne Lindstrom, a pediatrician who heads the WHO's Essential Program on Immunization. Dr. Lindstrom, let me start with you. It was last August, I think, when the WHO finished and endorsed this ambitious new document you worked on called the Immunization Agenda 2030, a global strategy to leave no one behind. So by that time, we were 6 months into the pandemic. We had no COVID vaccine yet. How did you decide what to make the document's primary goals? You know, pandemic, previously existing diseases, future pandemics? And if you are able to summarize for us, what is the document's focus?
So thank you, Cynthia. Well, actually, you know, this global, very ambitious agenda was, the development of it was made by so many different partners, thousands and thousands of input from all over the world, of all immunization stakeholders. And the work of it started before the pandemic. So actually, you know, the foundation, when we looked at what are the problems, what are the challenges, what are we facing in immunization today, through numerous consultations, you know, we built the agenda before the pandemic came. It hit, and I can tell you that we can see that the thought that was going into the agenda, immunization agenda, and the foundation we started to write holds still today, and even more today. I think that this immunization agenda is more timely than ever now, when during the pandemic we're facing, you know, we're seeing the hope being inspired by the COVID-19 vaccine rollout and the success of the rollout is so much dependent on the backbone of functioning immunization systems. And that is what the immunization agenda is about. Building strong immunization systems that can deliver equitable access to all immunization and throughout the life course, building primary health care that is accessible to every corner of the world, to every society, to the last child that did not reach, that are not reached by immunization programs. And so the agenda in itself is very ambitious. It holds up promise for a 50% reduction of those children, the zero-dose children, not being reached today, that they will be reached by the end of the decade.
I want to ask
500 new immunization introductions and 90% coverage. So really ambitious. Over to you, Cynthia.
You made a reference that I just want to emphasize there, in case people in other places didn't quite hear it, the zero-dose children. Let's kind of remind people what the agenda means by the zero-dose children and how big an issue that is.
So even before the pandemic, there were about 20 million children under immunized in the world, and out of those 14 million zero-dose, so-called zero-dose children, those that were not reached by even the first dose of diphtheria, tetanus, and pertussis vaccine. So not the first life-saving vaccine in life. So those are the communities that we talk about as zero-dose children. And that number has been stagnating for a very long time now, almost 10 years. We need to break that roof and reach those with a committed global community towards immunization, and to be able to, by 10 years ahead, say, yeah, we did reach, we did build out, we laid out a new immunization ambition to not let anyone behind.
So to Martha Ribor, I'd like to direct my next question to you. There's a line in the 2030 Agenda's introduction about focusing on a comprehensive response to the COVID-19 pandemic and a repair to the damage it has caused. As the UN's Shot for Life director, what do we know so far about that damage? What kind of documentation do we have on it?
Yeah, thank you, Cynthia, for the opportunity. Thank you for everyone who joined. I would just like to very quickly talk about Shot at Life, because I'm not sure everybody knows about my organization. And it's important for this discussion because we were founded 10 years ago for one very specific purpose, and that was building US champions for global immunization. And we were started because we learned that policymakers need to hear about vaccines and global health, not only from experts, but from leaders in their district and people who voted for them, to explain that vaccines are important and provide this tremendous return on investment. So 10 years later, more than 250,000 advocates, and in cooperation with many organizations in the US, but US government investments in global immunizations have doubled. So to advocates on from other countries, I just wanted to situate ourselves as a grassroots organization, then explain that real change is possible. So Cynthia, back to your question about what we know has been happening since the pandemic broke out and what's happened to routine immunization. Services have been reduced dramatically. And it's estimated that in this one single year, we've lost 20 years of progress as far as vaccine coverage. 20 years of progress sort of wiped away, and every year more babies are being born. Health systems have been stretched. They're grappling with treating people who are sick with COVID and not having the capability and the capacity to do routine immunizations. And then on the other hand, parents have understandably stayed away from health center settings due to fear of contagion. And according to new data, was just came out with a press release with WHO on Monday. There's 60 life-saving vaccination campaigns that are postponed across 50 countries. And this is putting close to 228 million people, most of whom are children, at risk for diseases such as measles, yellow fever, and polio.
Can you give a couple examples of postponed campaigns, just so people can get a sense of the kinds of places that this is going on?
That this is happening, I don't have the exact list, but this is happening really around the world, particularly in sub-Saharan Africa. We know there have been many measles campaigns that were planned, and we know measles is 10 times more contagious than COVID. And we're going to have a real situation when we start to see more outbreaks. And again, I want to be clear, it is not that governments are not, they're shirking their responsibilities. They are strapped. Health systems are strapped. WHO and UNICEF have not sent any guidance to pause these. It's simply, there are areas where it's just not safe to have these campaigns right now. So things will get back on track, but I think it's really important that we all understand this and advocate that there are adequate resources, because we know catch-up campaigns cost a lot more than routine immunizations. Really important we all emphasize. We have the know-how to get back faster. It won't take us 20 years again, but we need to be committed.
Are there other diseases, and this is I want to extend this question also to Dr. Wolody, but besides measles, that was a particularly alarming statistic that you just gave us. What's sort of top on the agenda for other vaccine preventable diseases that you are worried about recurrences of or great growth in because of the problems that the pandemic has brought health systems?
Chizoba, did you want to go ahead?
I have a particular way I'd like to ask this to Dr. Will, but I just wanted you to follow up on that for a second.
You wanted to follow up with me. Okay.
Yeah.
So you were asking what are the other diseases that we're worried about?
A couple of the others that are kind of top on the list. Yes.
Polio is a big one. We knew we're very close to eradicating polio, but the pandemic has set us back. That's of real concern. Yellow fever is another one. So yeah, those are some we're really focusing on.
All right. Dr. Wolody, we know that for years, children's ability to get vaccinated has depended in large part on where they live, right? Their parents' income, educational status, country, maybe their religion. So before the pandemic, which of the vaccine preventable diseases were most worrisome to you? And I want to ask you again, before the pandemic, what looked to you like some of the most promising moves toward equity in that regard before the pandemic?
Thank you so much for that. Before the pandemic, I think the vaccine preventable disease that has been most worrisome to me and to global audiences, measles. I think Martha mentioned that measles is very, very contagious. It is said that you can catch measles by just being in the same room as somebody who has measles. And we know that it's said that measles is they call it the canary in the coal mine, because wherever you see measles outbreak flaring up, it shows you that the routine immunization system is weak, is down. So children are not being reached with vaccination. So that has been a concern. And we know that in Nigeria, for example, where I come from, where I work, we have measles outbreak from time to time. I remember even when, just as COVID hit, there were some outbreaks in northern parts of Nigeria, which had to be addressed. And we know that there had been raging measles outbreak in DRC before the pandemic. So these are things that we see, and it really tells us that we must continue to place emphasis on routine immunization. And I think, like Martha said before, measles will kill more children than COVID. So if we take our eyes off, yes, definitely, if we take our eyes off routine immunization, we will be worse off than we were before. But you had asked, yeah.
A quick question, is that last distressing statement that you just made, measles will kill more children than COVID, is that because measles is so much more destructive to the unvaccinated than we tend to appreciate? Or is it because children don't tend to die from COVID at the rate that older people do?
So it's two things. One, measles is more contagious than COVID. And then two, children, are less susceptible to severe COVID and also death from COVID. So those are the two things that go together with that.
Okay. And what now has the pandemic, as you've been able to see, both within Nigeria and other places that you're looking at, what has the pandemic done to that? I mean, I was going to ask you in addition what some of the most promising moves were in those arenas, right? But what has the pandemic done to your concern about these vaccine preventable diseases?
So in the first few months where the pandemic hit, there was a lot of confusion. Immunization programs didn't know whether to continue or not. Parents, someone mentioned that earlier, parents were concerned about, getting exposed to COVID in healthcare settings. So parents didn't come to get vaccinated, get their children vaccinated, and health workers were actually strapped. They could not move around because of lockdowns and everything. So immunization coverage dropped. However, what has happened since then is that WHO came out with guidelines that encouraged, that provided advice to countries on how to safely continue to provide immunization services. And several countries now started their catch-up campaigns. Nigeria, for example, I know, did a catch-up campaign last year around August, and they vaccinated more than 100% of the children that they were expecting to vaccinate because there was already this backlog of kids who had not been vaccinated. I also know that Nepal, during the pandemic last year, Nepal was able to go forward with a planned measles campaign by putting in place the safety precautions and everything. So yes, campaigns were delayed and halted, but what has happened now is that the system is playing catch up, and so some of those campaigns have begun to be resumed in the different countries.
What did we learn? What did the community learn from the success of those catch-up campaigns that were working? I mean, that's a thing that I think a lot of us, at least in the lay community, did not realize, that there had been these occasional really successful revaccinate or efforts to get the vaccination going again. So what kinds of techniques did health systems and local health workers use to persuade parents to come back in and get those vaccinations?
Okay, there are a number of ways that the system was set up to provide services in the first instance and then to attract parents back. So to provide services, one of the things they did was to increase the number of times and places where parents could get their kids vaccinated, because you want to reduce crowds in the clinics. That means that you have to provide services for longer hours and then in more places. There was a lot of open air vaccination just to, create that, to reduce the risk of transmission. And then also the use of face masks, hand gloves, and interpersonal IPC, right? Disease prevention, sorry about that. The use of those things, the visible use of those things actually engendered confidence in parents, because they could see the health workers wearing the mask, and there was a lot of campaigns that went out, educational information. Right now, most people know about vaccines than ever before because of COVID. People are tuned into vaccination because of COVID. So the advocacy communication efforts that were put out kind of encourage parents to come back. But I think the most important thing really was that concerted effort for catch-up campaigns. And so it required both fixed sessions, outreach sessions, mobile sessions, and like Martha said, it also required additional funding. So campaigns cost much more than routine services.
Thank you. That's really interesting. So Anne Lindstrom, there's a recent disturbing statistic from WHO's Director General, who said that in rich countries, at present, we're seeing 1 in 4 adults. This is about the COVID-19 vaccination, right? So in rich countries, we're seeing 1 in 4 adults with at least 1 dose. He said this just a few weeks ago, so I don't imagine the situation has changed dramatically since then of the COVID-19 vaccination. In low-income countries, 1 in 500. So my question to you is, explain COVAX, if you will. I know that this is a learned audience and many people will be familiar with COVAX, but I wasn't before preparing for this. Explain what it is, how it can help, and whether there are any other international moves that you see underway to address this very, very serious disparity in who's receiving the COVID-19 vaccines.
So thank you, Cynthia. COVAX was set up to increase equitable access for COVID-19 vaccines. It's part of an initiative called Act A, which actually talks about other tools as well, diagnostics, therapeutics, and then the COVAX itself is the pillar of the vaccines. And so what we're working on is a large collaborative effort between all the way from research to delivery, and make the chain fast and equitable to mobilize resources, support research, and organize the strategies, recommendations in a way that very quickly the vaccines may be licensed and used in countries, and then support in any possible way the preparations and the delivery of the COVID-19 vaccines. The figures you cited are luckily a little bit better now. The COVAX has delivered about 50 million doses.
50 million? 50 million? Okay.
50 million doses. And so that equity gap is closing, but it's definitely not good enough. It's still high income countries and upper middle income countries who've distributed many more doses per 100 population compared to low income countries. It's still a magnitude of 10 between. And we are worried still, particularly now that the supply through COVAX is a bit slower than it was from the beginning. There are many complexities of getting the doses and enough doses. And one of them is that one of the vaccines from India, the AstraZeneca SII doses, have been halted because of the pandemic in India and the heartbreaking situation in India and the need for domestic use of these vaccines. So we see a slowdown, but still that is the mechanism where we're also working not just with fundraising, getting the doses out and preparing countries, but also advocating and just saying this is not fair. We need all countries and all target populations wherever they live that are most at risk of COVID-19 vaccine to get access to these life-saving vaccines. And as the Director General says, nobody is safe unless everyone is safe, and that is so true. So we're pushing for high-income countries to donate doses so that the number of doses that can be distributed through COVAX will be increasing.
And Lindstrom, is COVAX being organized through the United Nations, through the WHO? Where is the sort of central headquarters, if you will, of this organization?
There is no headquarters. It's a virtual headquarters, you can say, and it's a multi-collaborative. You have the UN organizations, you have WHO, you have UNICEF, but you also have CEPI and Gavi Alliance. I don't know. It's absolutely fantastic to see the collaboration, because when we know we have a goal, we know why we're there. Everyone takes off their hats. We work virtually. They take off the organizational hat kind of and just roll up the sleeves and work together. It's been really extraordinary to see the efforts made. And it's between this and many more organizations supporting. I work on the delivery side to try and help prepare the countries for delivery. And in that, we have a multitude of country based organizations, regional based organizations, and a collaboration across, I mean, I don't know even how many organizations are up and trying to support countries to deliver these vaccines.
Great. Lubna Hashmat, nice to see you back with us. Can you tell us a little bit about, at present, the vaccine situation in Pakistan? We've been talking both about delivery efforts, about the message that this new agenda is hoping to bring, and also about complications caused, of course, by the pandemic over the last year. We've all been reading a great deal in recent days about the terrible situation in India. I don't know whether it is as bad as Pakistan. Maybe you can just give us a report from what you see close up there.
Yeah, sure. Thank you so much. If we compare our country with India, the situation is not that bad. But if we analyze the closer context, there might be less lab tests. There might be less reporting of the data, because what we see in the hospitals, that the uptake of services is relatively low. People do not want to access health facilities during these pandemic, just to prevent their other family members from the pandemic, and hospitals are seen as more contagious than their houses itself. So when we see the immunization backsliding status, it's gone down as low as 78% from the baseline of 2019. So if you see September 2000.
I'm sorry, Lubna, could you clarify that stat for us? You're 75% less than you were?
Decline. Yes.
Yeah.
Ooh, yes.
Okay.
If we compare results of September 2019, and if we see statistics of March 2020, the backsliding percentage was as low as 78%, vary from area to area. The 78% is from one province, which is Sindh, which I'm quoting, but we did a bit of sample testing in each province to know what is the extent. So it varies. In some areas, tribal areas, we already had very low immunization, but it gone more worse than it was before. The situation is that when we were in August 2020, it was started to going up, and again, it's going down. The situation is not stable so that we can have confidence that we are saving lives, we are protecting children, we are in serious danger of outbreak. Although we recently concluded a typhoid campaign, we are planning for measles rubella campaign, but with a lot of caution and a lot of compliance to SOPs, and due to all those pandemic dangers, the social mobilization, demand generation, outreach activities, group interactions, all are very, very limited. And our hands are tied up that we're investing so much money, will we get the same results? Yeah. So this is a big question mark.
So Martha Rabor, I'd like to ask you to sort of take off from that. The pandemic has obviously provided some extraordinary challenges. I have the sense that it also may have provided some opportunities by way of better vaccine distribution. And I'd like to ask you about sort of both of those things together. I mean, as someone commented just a few moments ago, vaccines are more in the public conversation, perhaps than in any of our living memories. Awareness of need, visibility of an alarming sickness that previously, where previously vaccine preventable diseases were more visible only in the lower income countries. How is the situation changed, and what do you see that's possible by way of optimism? Oh, we just lost your, we lost your audio. We need you to hit your mute button again.
Thank you, Cynthia, for the question. Absolutely. I think there is an opportunity here. I mean, vaccines are the solution, right? This whole world has been affected by the pandemic. economies, families, businesses, entire health systems, and vaccines are our way out. And people have learned something that, a lot of us at Shot at Life and other global health organizations have been saying for years, which is an infectious disease anywhere is a threat everywhere. So none of us are truly safe from this pandemic until we're all safe. So once vaccines, as Anne said, through COVAX and other mechanisms, once vaccines are equitably and widely distributed, then we're going to be able to talk about the world recovering. So specifically for our work, I think as our grassroots champions, travel to Capitol Hill virtually right now, it used to be in person, and talk about the importance of the US, strongly funding these global immunization programs, it is understood in a way it was never understood before. Policymakers are open to these meetings. They're understanding the tremendous ROI of global vaccines. And I have to say, I think we're incredibly fortunate, and the timing couldn't have been better for WHO's Immunization Agenda 2030 to come out, because with its focus on vaccines across the life course, highlighting the lives saved every year by vaccines, I think it couldn't come at a time where there's a more receptive public and policymakers for understanding, again, this incredible return on investment and how the whole world needs to come together and make sure that people around the world, no matter where they live, have access to this incredible public health tool of vaccines.
What do you think the COVID-19 vaccines have done to the problem of vaccine hesitancy or vaccine hostility? As a layperson, I would wonder whether on the one hand, at least in the United States, we have the sense that anti-vaxxers, to put it bluntly, seem dumber than they used to, given what's going on right now. And they are more sort of publicly reviled and mocked by a large majority of the population. On the other hand, there's an international conversation and movement underway that's given them perhaps some momentum. How big an issue do you think that is, both here and in other countries where the hesitancy may have taken other forms?
Again, a great question. And I just want to be very clear, because we work in this area, there is an enormous difference, a gulf between people who are vaccine hesitant and people who are anti-vax. And people who are vaccine hesitant, I think, I have a lot of respect for. I'm a mother. I remember when I took my child to the pediatrician and they showed me the list of shots my baby was going to get. It gave me pause. So I think it's fabulous that we have so many resources now, and we've seen influencers from rock stars to actors to faith leaders all coming out and explaining why people can feel confident about the COVID vaccines. Although they were developed in record time, there were no steps that were skipped. So I think it's been a tremendous moment for people who are vaccine hesitant, because they're able to get their questions answered, whether it's around the COVID vaccine or vaccines in general. To pick up on anti-vax, I personally don't think, and we do a lot of studies, I don't think it has grown as a group, but we've also worked a lot with a researcher from George Washington University. What has increased are bots, Russian bots particularly, but other ones that are looking to sow division and doubt. So we do see on social media a real rise. And unfortunately, social media is international, right? So it can be seen by everybody around the world. There has been a rise in social media activity by anti-vaxxers, but I still feel like in the US, more than 90% of parents immunize their children. It is not a controversial lightning rod issue, as you may think if you look at social media. However, I have noticed internationally, there are places, and I'd love to hear Chizoba, because I've heard her speak about this before, in Nigeria as well as in Senegal, where some of these online actors have, again, fueled these stories of conspiracy or other reasons why WHO or other international actors are looking to push vaccines for other motives. And again, I think it's a relatively small minority and something that we need to pay attention to. We cannot be complacent, but where we feel like there's an opportunity is among, vaccine hesitant people who I think are absolutely justified in wanting to seek out more information. So it's up to all of us to provide information and to empower community leaders to be able to provide the information and have these discussions.
I know Ann Lindstrom had a thought she wanted to add to that, and then I do want to ask you, Dr. Wolde. Yeah.
Yeah, I just wanted to say, because I just came out from a very interesting discussion with 500 of national and subnational immunization people at different levels, discussing the immunization agenda. And this topic about what will COVID-19 vaccine rollout do to the trust in vaccines, it was very much on the agenda of everyone's mind there. And something that did worry me was that a few of them did talk about the spillover. So when we talk about COVID-19 vaccines, and people, hear different things, there are some safety signals. There is short shelf life of some vaccines that have come out. I mean, real concerns that we need to take very seriously and communicate really, really well around, so that people can take informed decisions. But the spillover to the regular immunization services. So they were speaking about the doubts that could be contagious when it comes to the COVID-19 vaccine rollout. So I think it can go in both directions, Cynthia and Marta. I mean, it can be increasing the trust. We can see that what it can do to the pandemic and gets us closer to our near ones, hopefully, with these vaccines. But it can also go the other way around. So I don't think we've seen the end of this yet, but we need all to be mindful. And I think you're right, Marta. I think both each community leaders, the key people in the community, but I also think that the central people here are the healthcare workers. It's not us at the global level. It's really that the healthcare workers, the trusted healthcare workers who are sitting beside the mother to take decisions. That's the person who needs to have all the informed and all the information, all the empathy, all the time, which is difficult many times, to answer the questions, right? And so, yes, we have a lot more to do there. And I don't know, we all need to commit in all different levels of getting the right information out and to the right people who can actually have those informed conversations with the mothers. Yeah.
Chizoba, could you respond to what Martha Rabor was saying about challenges that you face, particularly in Nigeria, or familiarity you may have with groups that see some reason to get in your way as vaccinators?
Right. So absolutely agree with what Martha and I have said. We actually just completing a study in Nigeria where we're looking at COVID vaccine hesitancy among health workers, adults and older adults. Yeah. Wow. So what we are seeing with that is that there is some hesitancy among health workers, but it's not as much as we fear. So we're seeing about 3-4% who say no, they will not get the vaccine, who say no. But then about, would say around 55% say yes, they will get it immediately. That between that 55%, you have about some kind of around 30% or so who are saying, I will wait, I need more information. And this was before the vaccine was introduced, before we received the vaccine. So health workers are definitely the #1 source for information for the general public. And we, like Anne said, we need to make sure that they are equipped with the information. And some of the concerns they raised were around the safety of the vaccine, were around some of the conspiracy theories that, that are circulating. Once those conspiracy theories arise in America, they will find their way in Africa. Even if they arise in Africa, they will also find their way in America. So because we are all connected, so we see the conspiracy theory also being an issue. And so I think that we need, more than ever before, we need to listen more to the communities, right? To the people, either through repeated surveys. We've never had this fast changing, environment around the vaccine. So when we did our study, some of the concerns were around the conspiracy theories. Another survey has been done more recently, the concerns around the suspension of the AstraZeneca vaccine, suspension of the
You mean
Johnson
with,
&
you mean
Johnson
with the
vaccine.
suspension being viewed as another kind of conspiracy?
As a concern, a safety concern. So there are safety concerns. So what this means is that anything that happens in the US or policies around these vaccines will also have reverberations in Africa. And so we need to keep our pulse on the finger, or our finger on the pulse, to understand where people's minds are with regards to the vaccines. So that's one major thing that we're seeing in Nigeria. And the immunization programs have to be nimble with responding to information, using influential people, bringing out Q&As, talking on social media, talking in the media. We need to actually saturate the social media with the facts and positive information. It's almost like a war of words. We need to win this war of words by, saturating the airwaves with the positive information.
There's a follow-up question to that I'd like to ask both you and Lubna Hashmat, which is about the particular role of women in vaccination campaigns. I believe that both you and Lubna Hashmat have spoken, Lubna Hashmat, I know you have in particular, about women sometimes, women and girls sometimes being denied vaccines because of cultural concerns connected to receiving medical care and so on. But I think they can also be some of your best champions and messengers, both as parents and as health workers, right? So, but maybe if you could start by talking about women in the Nigerian context. You're working with a women's organization, and then I'd like to turn to Lubna Hashmat to ask her about that.
Yeah, I think what you're touching on is the gender issues around immunization. And it's very clear that there are some gender considerations. For example, in Northern Nigeria, for example, if you're a man, if you're a male vaccinator, you can't go into the home to go vaccinate. You can't go into the home.
You cannot go into the home.
Without a female. So where you don't have enough female health workers, that provides like a gender barrier to access. And that's a big concern. Another concern in terms of gender is this issue of autonomy, right? And women needing permission from their husbands to get their children vaccinated. So if we are not involving men in the immunization, education, and advocacy and all, we will be missing a lot of opportunities for women to get their children vaccinated. So, but there are also positive signs that women are, taking on agency. I know a program that we worked with in Niger State had female vaccination champions in communities. So these are women leaders in the community. Maybe they have, businesses in the community, and all they are seen as leaders who then take on immunization as something that they champion and talk within their communities to let both men and women know the value of vaccination. I think women are a great resource when it comes to community mobilization and advocacy, right? Because they can advocate in the boardroom, like they say. They can also advocate in the bedroom. Right. So, so women really are a very, very important resource for immunization going forward. But we must not forget that there are some areas where gender issues pose a barrier to immunization, like I mentioned earlier? Thank you.
Dr. Wanadi, thank you. Lubna Hashmat, you have also spoken, I think, about the particular challenges and potential for involving women in vaccination campaigns. How is that looking now, especially in light of the current vaccination situation?
Yes, thank you so much. The situation is mixed. In urban areas, cities, mega cities, women are all right to get vaccinated from male vaccinator, but in remote areas, hard to reach areas, conservative areas, culturally sensitive areas, it is almost near to impossible to get the vaccination of a woman because it requires full opening of your sleeves, and it is not allowed in the religion, in the belief system, plus the culture. And the second challenge is that in Pakistan, we do not have a good public transport system available, and carrying a women requires transport which maintains the what we call it in local language, the parda wheel system, that women is protected, not touched by any of the opposite gender, and is respected and safe, and all those, which requires a cost. So people cannot afford to have a separate transport rented vehicle dedicated only for women, just for vaccination. So why not confine women in a house just to protect instead of vaccinating? So these are the issues which are very important to consider. But I mean, when we plan anything for delivery of vaccination, we have to make a decision about human resource also. We have to make about delivery options, that how, so government has recently announced that we will be ready to provide home service, for example. Even if they provide home service, and if the vaccinator is male, unfortunately, this is not going to work out.
Right. So do you have to deal with the argument that this is another, I think this is what you were just saying, I just want to confirm, that from a certain perspective, this is another argument in favor of purda, right? That the idea that we're keeping women at home to keep them safe from social contamination, but also from germ contamination. And so you have to figure out how to answer that argument as you persuade people to vaccinate and to bring their children in for vaccination. Am I understanding that correctly?
Yes, what I see this situation is that previously, before the pandemic, people, there were different segments of people. So there were hardcore refusal of childhood vaccination, for example. There were some hesitant people. There were some people who were unaware. But now everybody talk about pandemic. Everybody talk about virus. And this is the first step when we start raising awareness. Previously, people did not have a single information about vaccine or virus or any outbreak or anything contagious. But after this COVID-19 pandemic, all children, all, no matter they are educated or not educated, they're remote or they're in urban areas, everybody talk about them. So it is an opportunity for people like us, that how do we capitalize and raise their awareness? And if we have correct information there and then, we can mobilize. This can be done.
So Martha Rabur, I look back at the 2012 WHO vaccine plan, and there's a chart. It shows 25 important vaccine preventable agents and diseases, not just polio and measles, but also anthrax, tick-borne encephalitis, and of course, not on the list is COVID-19, right? That was 2012. So my question to you is, when you think about the Agenda 2030, 2030 seems like a long way away. It's not that long now, but how do we prioritize in a vaccine agenda like this, attending to the illnesses we know about, while also preparing for the next pandemic and the ones we don't know about yet? Oh, you're still on mute. You're still on mute, Martha.
Sorry, I clicked it.
There you go.
Thank you, Cynthia. That's a great question. You know, and I would say it's one of the real strengths of IA 2030 is that it is not only solely focused on vaccines, but as my fellow panelists have pointed out, vaccines are the backbone of primary health care. Primary health care is the backbone of universal health coverage. And that is what we are all working towards. Vaccines, childhood vaccines help set up lifetime habits and an awareness. And for some people, it's the first time to visit a health center. So vaccines have many ripple effects. And I think something, if we've learned anything from this pandemic, it's that we need more resilient health systems, whether it be in India or in the United States. We have a lot of weaknesses here too. So I think what is so wonderful about this strategy is that it not only is showing the benefits of immunizing people to protect them against infectious disease, but it's also showing these ripple effects and why we need to strengthen primary care, why we need to strengthen health systems around the world. It's the only way, and in some ways, again, not to be too silver lining about a very tragic pandemic, but it has awoken the world to so many things so many of us have been saying for so long. We cannot be safe where we are until the whole world is safe and protected. And I would add to that, now more than ever, we need champions for global immunization. We need advocates. We need everyday people, not just health experts, not just those of us that work in this field. We need everyday people to reach out to policymakers. And we can't miss this one in a generation opportunity when policymakers are receptive and they understand these messages. We need to reach out and we need to push for additional resources and we need to strengthen health systems. I hope this is the last pandemic we'll see in our lifetime, although it seems that's unlikely. So if we don't want to go back to being separated from our families, having our economy shut down, and all the terrible, to say nothing of the death and suffering of so many people, we need to double down now and strengthen health systems and really use this opportunity, all of us, to reach out to policymakers and let them know that vaccines are an incredible return on investment. And we need to do this now. We simply cannot wait any longer.
So as we move toward the period where we'll start answering the questions of the people around the world who are listening in on this, just in a couple of minutes, there's a question. This is a big question, and I think I'd like to start by throwing it at Anne Lindstrom, but I'm also interested, particularly Dr. Wanadi, in your thoughts about this. How would you answer if I'm a health minister, let us say, from one of the richer countries? So this question applies to the pandemic, but even previously. How do you answer me if I say to you, look, I'm very sorry for the situation in the middle income and the lower income countries. I know they really need the vaccine. I know our rates are much higher, but I'm sorry, my primary obligations have to be to the citizens of my country. That's where my resources are going. How do you answer that response? Because you know that's the feeling for a lot of lay people as well as some health officials within their own countries with resources. So Anne Lindstrom, I'd like you to take a first shot at that, please, as it were.
I would say that unless you do this now, the COVID-19 pandemic risks to go on and go on. Unless we stop the virus at all places at the moment, it will come back at us and bite our tail. We need to be solidaric. We need to think large. We need to see this as a global public health threat and respond to it as a global public health threat, right? We know the variants, the mutations that are coming. We learn more and more about them every day. We don't know the end game yet of the limits of the current vaccines that we have and how we will be able to respond to those new variants coming up. So the best way is now to think globally for the whole world. I think that would be what it will come back at you. You will not be able to get out of this pandemic unless we look at it as a global public health threat. And the global public health threat is a security to all, to all of us. And that, I think what you invest today, the dose sharing you can do today will pay you off multiple times in the end game.
Dr. Wondy, is there anything you would add to that as someone who has lived both in Nigeria and in the United States? So I'm sure you've heard this argument articulated before, right?
Right. What I would add to this is that most of us in the world, even in the US, have family members in other countries, or even have plans to visit other countries or plans to invest in other countries. As long as we have a COVID pandemic raging in parts of the world, it means that maybe you can't, travel freely for your vacation to those places where the pandemic is still raging. Maybe your family members cannot come visit you where you are in the US. But I think there's an economic argument to be made as well. Because I think as long as there's COVID raging somewhere in the world, even in the US with the vaccinated population, there may still be some restrictions that will affect trade and travel and commerce. So it's actually in the best interest of the rich countries to support vaccination by sharing doses, donating doses, and sharing technology know-how for vaccination production to be ramped up in other parts of the world. Thank you.
So we're going to turn, thank you very much, Dr. Wondy. We're going to turn to some of the questions that are coming in from various people in the audience. Yaso, I'm going to mispronounce your name, Yashoyini-sen, so my apologies in advance, says, thank you, very good morning and evening to all the panelists, thank you. This person writes, I'm from India, and caste is a very important social determinant here, even with regard to vaccination. So how can caste lines be overcome, given that the health workers themselves can be unwilling to vaccinate lower caste babies, or lower caste parents may be unwilling to visit a health center run by higher caste workers due to fear of discrimination? What a particular and difficult question. I don't know which of you might want to give a response to that. Yes, Lubna Hashmat, please.
Yeah, because we have also observed a bit of it in our part of the world. When we have upper caste, we don't call it caste, we call it tribe, upper tribe person. For example, king of the village is vaccinator, he is not going to vaccinate the vice versa. So what we have done is we have developed a team of local health workers from all ethnic groups. So before we begin our HR planning, we have to have a social profiling of the area so that we can plan accordingly. It can't be that every individual of a different ethnic group will get a different type of health worker. It comes from the national level thing, that how do we analyze overall social data. So previously in the medical thing, the element of social was very weak. But after this pandemic, it has highlighted importance of all those social analysis and social strategies into all those vaccination strategies, if I may call it, or any health related activity. So how do we combine both hand in hand and then plan for it? So you have to have health workers from all those classes so that you don't have any discrimination for different types of groups. But simultaneously, we should not be supportive of this class system. Simultaneously, we should be working or raising awareness to dilute those class system eventually, because it has to, if we are talking about one world protected, if you're talking about IA 2030, equity and justice, so we have to talk about diluting those discriminations based on caste or ethnic or color or creed or religion or area. Over, thank you.
My apologies. I think it was my internet that just froze there. So I don't know whether you were able to continue while I was gone, but what I was about to ask while I was frantically pulling my internet back up was Martha Ribor, whether you had additional thoughts about that particular problem that had been the question that had been asked out of India.
Yeah, I don't have really additional thoughts, but I do want to echo, because it's so important what Lubna said. One world protected, health equity, universal health coverage, all lives having equal value. I think we really need to push the agenda of making sure that healthcare services are available to all. So I would just echo some really great points that she made, and as well as the approach of being hyper local, whether it's by tribe or it's by village or within a village, a caste. We need to reach all people with health services. And we know that right now we need to reach all people with vaccines. So I think really would just echo what Lubna so eloquently described.
I had a question also for Dr. Willoughby. There were reports out of that you've no doubt seen out of a study in Africa of the high efficacy of this University of Oxford Novavax children's malaria vaccine. Can you tell me about your response to that and how that may fit into the 2030 agenda and its possibilities? Malaria is a very big deal that has not previously been for children particularly receptive to vaccines.
Yeah, I think that's really exciting news about the efficacy results. Malaria is one of the biggest causes of morbidity and mortality in Africa. And so if we have a vaccine that can prevent that level of burden of ill health, then that's really a positive thing. And I know that there will be high demand for this vaccine because people know what malaria is. It's just like, everybody knows about COVID right now, and the people who are not afraid of it or what, there's a high demand for it. I also think that it provides an opportunity for us to strengthen the immunization program, as well as the linkages between immunization and primary health care more broadly. Because malaria has been, of course, there are malaria programs, nets, and all that have been in place for a long time. And so with the introduction of the vaccine, malaria vaccine, I think that gives us another avenue to strengthen those linkages. I'm really excited about the results. The major other thing will now be financing. We hope that there will be financing and support to introduce the vaccine, and then over time, of course, the government can take it on more sustainably. But that's really something that we've been waiting for a very, very long time, and I think is around the corner.
Yeah, it's very exciting. We have another question from India, which is about children and COVID vaccine availability or unavailability. The questioner, who appears to be from India, says that the new wave shows even children getting infected, more and more children. So I'm not sure which of you might have some thoughts on COVID vaccine, the potential for the vaccine getting to children. We know that in the United States, at least, we've learned that it's still in the final stages, we hope, of safety testing. Where does that look? I'm not sure. Anne Lindstrom, maybe you're following that. Martha Ribor.
Yeah, I'm following that. Most of the manufacturers are currently doing clinical trials in children, and so there will be. But however, now they are licensed. The majority of them are licensed from 18 years and above. We should, however, know, that the children are much less at risk of severe disease of COVID-19. So I think, we need to focus first on those adult medical risk groups, health workers that are at front line of getting severe disease of COVID-19 vaccine. But yes, there will be coming more data that can make us confident that these vaccines probably can also be given in younger age groups.
Martha Rabor, is there anything you would like to add to that, both in terms of the availability of the vaccine to children and perhaps in a broader picture, how that may affect vaccine campaigns more generally per the 2030 agenda?
Yeah, I mean, I think it's an interesting question, but I'm going to go back to what Anne said. We have still not covered healthcare workers and the most vulnerable people around the world. We are very far from that. I have children. I'm a mother. I hope that they will get the COVID vaccine eventually, but they're not the ones for now going to the hospital in large majority. There are more cases now. So well, I'm certainly very interested in what that could mean down the line. I really don't want the world to lose focus on covering that, healthcare workers and most vulnerable around the world. That really, to me, is where the emphasis should be right now.
One of our questioners asks, how can we stop the disruption of the existing vaccination? Now, how do you find a health machinery? How do you help a health machinery that's already stretched, responding to the emergency situation? So in our conversation this morning, we've certainly alluded to the impact on existing health machinery, but we could maybe get a little bit more specific. I'm not sure which of you may be able to give us, perhaps Lubna Hashmat may be able to give us a more vivid example. And Lindstrom, it looks like you might have some thoughts on this, of what actually happens to the existing health machinery of a nation that suddenly gets slammed with this enormous new challenge. And Lindstrom?
Initially, yeah, sure. And please carry on.
Well,
let's start with Anne Lindstrom, and then I'll go to Lubna Hashmat. Yeah, thank you.
Yeah, thank you. And actually, it's also responding to Dr. Suresh Kishan Rao, who is also asking about, the opportunities, because we talked about disruption to immunization programs due to the pandemic, but also to the rollout of the COVID-19 vaccines. But there are also kind of opportunities at the same time, because with all the attention, there is a lot of resources coming to countries at the moment to support, for example, restoring and building out the cold chain equipment, which can be serving way beyond after COVID-19 vaccines, may not be, taking up all the space in the fridges, but actually for the routine immunization. We see a learning agenda and an increase in safety monitoring capacity, data monitoring, digital tools, which can increase the effectiveness of the delivery of immunization programs, logistics, the training that many healthcare workers are doing right now that can also be staying on, after. So there are opportunities and risks at the same time. I think it's both. I think I'll stop there and let Lubna continue as well.
Lubna, please. Thank you.
Yeah, sure. What I have observed in the country is that, for example, if we have 100 health workers, and before pandemic, out of 100, 60 were focusing on childhood immunization. So initially, when pandemic started occurring, and nobody had any clue that what is going on and how do we trace the cases and how do we contain it, all vaccinators were appointed for case tracing. So
I'm
for
sorry,
3-4 months,
all vaccinators were appointed
were deployed to identify cases, collect the samples, so mobilize people for quarantine initially last year. After 3-4 months, when government realized that in order to contain the pandemic, they have compromised the very important thing on childhood immunization, these re-strategize, and then, but the major stress is on the human resource, that we do not have immediately trained human resource available, which we can deploy for both in a balanced manner. So one thing is compromising on the other thing. And it is at the moment very challenging. And this human resource thing cannot be something that we can purchase from the market. This is not cold chain. This is not vaccine. This requires some training and a process. And something. So it is very, very difficult situation. It is a big challenge.
Anybody else want to add a thought on that?
Yeah, even
Yes,
even
Dr. Modi.
managerial, yeah, even managerial and coordination, requirements has increased, right? So in Nigeria, for example, there's a team that's focusing on the COVID vaccine rollout and the response that's requiring, that's indicated in that. And then there has to be another team that's focusing on routine immunization and making sure that that does not fall through the cracks. So that's required more technical assistance and more
twice as many
technical
people,
support.
right? Yeah.
Yeah, definitely twice as many people. And then, but the thing is that with the rollout of the vaccine, unlike polio, which is a drop that you could, mobilize people who are not, well, they will be trained, but they don't have to be trained in giving shots. The COVID is a shot. So the people who are going to give the vaccines are going to be people who have, substantial amount of training and experience with giving the shot. So the human resource challenge is really a problem, and it will, right now, there is supply shortage, right? And so we've not really started vaccinating the entire population. We're still starting with healthcare workers and older adults. And in Nigeria, for example, we've just given out 1 million doses, 1 million doses. But when more supply comes, we really have to be ready for the human resource requirement that will keep the COVID vaccine rollout going, as well as routine immunization programs.
Well, that segues very nicely into another question that has come in, which is, we're obviously in an extraordinary surge of passionate interest in vaccines and the question of vaccines in this moment, right? One of our attendees asks if and when the interest and financing for COVID vaccine starts waning, as we know has happened from previous pandemics. How do we keep countries ready to react and respond to future pandemic threats? How do we keep systems ready? I'd like to ask you that, and then I'd like to ask you all to sort of send us off with some closing thoughts on the most important things that we should take away from 2030. But let's address, first of all, that question about, how do we brace for the inevitable, if we get this thing fully under control, the inevitable, like, wow, okay, I don't have to think about vaccines anymore, but we've got that behind us. Martha Ribor, you want to take a crack at that? Yeah. Okay, Lubna, please. Lubna Hashmat.
Yeah, what I feel that we have to focus on 4 things. One is there has to be a constant watchdog function to see and observe if we are going to have the epidemiological studies or any research unit which monitors, because for COVID, when one virus started appearing, nobody was very serious about it. And that was the major mistake, that it spread out to the entire world. So it requires a very close unit, global unit, which steer or watch appearance of any other pandemic in the world. Second is that we have again a global think tank thinking about building capabilities of all countries, regardless of their social and economic status, be it developing country or developed country, that we prepare army for protection of the country. We have to have an army of health workers ready for responding to those emergencies if it occurs. And the third unit is that we invest in innovations constantly. Either it could be technological innovation, or it could be vaccine related innovation, it could be demand generation related innovation, but there has to be innovation unit working based on all those watchdog data or information, and they produce something in the market, in the society for discussion and for refinement and for all those. And the fourth is, as we have, like in our country, we call it disaster management system. So there is an authority which is responsible to respond to all those emergencies, be it man-made or any a natural disaster. So we have to have health disaster management authority, so that if in case any of these pandemic occurs, there is a rescue immediately rolled out in the world to protect all of us.
That's quite an agenda, Lubna Hashmat. Thank you. I think that's a good send-off to get us started with our closing thoughts for each of us. Dr. Wandi, if you were to summarize what you'd like people in this audience to walk away with as they think about the 2030 agenda and its most important missions, what would you suggest?
So for audiences listening to this, I really want you to consider that the next 10 years is a period of opportunity that COVID has ushered in. And it's important that everyday people in every country be really engaged in immunization and supporting and promoting immunization because of the health benefit, the economic benefits, the social benefits of vaccination. And we have to be advocates for immunization. We know that there's going to be increased requirement for funding for immunization programs. So we need to advocate to our governments to secure the financing that's required to promote and sustain immunization programs. The IA 2030 has really brought us together. It was developed in a collaborative manner. So country programs should own the IA 2030. They should take it and make it their own, make it work for them, make it fit their context. And IA 2030 has everything in it. And then civil society organizations, my constituency, I really want to call on civil society organizations to be actively involved in supporting immunization programs, to hold our governments accountable, to hold ourselves accountable, and to make sure that when we come to the end of this decade, that, excuse me, that those 10 million zero-dose children that we started out, we would have brought them down to at least by 50%. That's the goal of the IA 2030. Let no child, let no community be left behind on the benefits of immunization because of where they were born or where they live. We can all be part of this movement for IA 2030. That's my plea to all watching. Thank you.
Very eloquent plea. Martha Rabor, would you like to add anything to Dr. Wolnovi's eloquent plea?
Absolutely. So first of all, I wanted to thank everybody who joined today. Thank you for caring about this issue. And I'd like to challenge all of you to think about how you could become an advocate for vaccine equity if you're not already one. Now more than ever, we all have a role to play, and we must lift our voices and explain the value of vaccines, as well as the importance of their equitable distribution in order to protect us all. And, you know, we can't say it enough. We have a historic opportunity to leverage this time when people across all societies and all around the world understand the value of vaccines. So let's use this opportunity and commit to those 10-year goals of the Immunization Agenda 2030. As Chizoba said, we want to half the number of no-dose children over these 10 years. We want to achieve 90% coverage for essential vaccines given in childhood and adolescence, and complete, this is an ambitious goal, but one we can reach, 500 introductions of new or underutilized vaccines, such as those for COVID-19, rotavirus, or HPV. So I want to thank everybody for joining, and I would ask everybody commit to helping working with all of us to achieve these very important goals outlined in IA 2030.
Dr. Ann Lindstrom, is there anything you'd like to add to that as someone who actually helped shepherd? I mean, I know all of you helped shepherd this document through.
No, I just want to add that I'm so happy to hear so many voices around IA 2030 right now, and that it really is a collective responsibility. It's a collective ownership, and it's a collective way that we all need to work on it to make it happen. The important thing is to not let down the guard now. You know, political leadership all around the world have understood and see that this shock of the pandemic, what it has done to us and our societies. So we need to, I agree with Shisoba, hold them accountable. There needs to be investment in primary healthcare, supporting good delivery of immunization systems. We need to support the research and innovation to continue to deliver life-saving immunization and strategies to deliver them. We call on every government around the world to look at the agenda, the collective outline that we've put together, and do their own national immunization strategy. And I also think that when it comes to, I think the global health security, we will not forget this shock in some time. I don't think that we will look at and then say, I think there's going to be many, many discussions about what did we learn? What can we do better? And so I think that the backbone of global health security, one piece is immunization. There are many other important pieces, surveillance, that are key to immunization. We all need to work on all the building blocks to make societies safe in the future as well.
I want to thank IVAC for helping make this thing come together. And thank you very much to all of the, not only the panelists, but also all the people from around the world who joined us for this program, and who I hope will be joining us later on to watch the recorded version of it, which will be available to you all. Thank you, and have a good morning, good day, or good evening, wherever you are.
Thank you.